Is there anything that you guys have learned with these devices or like this set of tools? I guess like any kind of illustrative points, like learning, like growing pains along the way. That's like, oh, this is a trick that I learned that makes more sense. Or this is why I start with T24, then go T20 and not T16. I don't know. I'm just trying to uncover any gems. Like you would be surprised like how much you guys like have built-in knowledge. I'm trying to see if there's anything like you guys learned along the way and like this is how you do it now. Ripal, we can start with you.
Sure. I mean, some basic things. Number one, look, I think a large bore catheter is needed for large thrombus removal. So for that reason, I like to go with the T24 every time. And it's surprising how much clot you can get out with that. Couple things, when you're pulling back on the syringe, if you've never utilized the device, if you see free flowing blood, that means you're not on clot. So at that point, you want to reposition the catheter. That's obvious. If you pull it back, and you get very little, you're getting a little bit of anything, or you get kind of a little bit of a slow fill. That point we'll do what's called a double. So basically you just disconnect it and basically do a second aspiration on there. And that will and at that point, if you're getting kind of the same thing, then you slowly pull the catheter back. You might be on a really big clot, or you might be against the wall of the vessel, and you slowly pull it back until you get a lot of clot out. Or if you're getting nothing out, then you have something called a lollipop, where you can imagine you have a giant thrombus, which is kind of partially ingested by the device. And the only way to really get that out is to drag the entire catheter out of the body. And you want to make sure that, you'll get this giant clot, sitting inside your catheter. On the left side, before we had the T20 curve, we were using the T24 and just the angle of the left pulmonary artery, the catheter would you end up aspirating right on the wall of the left pulmonary artery. So the T20 curve really prevents you from doing that. You can get it much deeper engaged into the left pulmonary artery, and it really does work. You basically can aspirate a large amount of clot, and sometimes you'll basically be in a very similar situation where you've aspirated and you're getting there's nothing that's coming back. Maybe you have a big clot engaged on it, and what I would recommend in that situation is as you pull it back and you get up to the T24, now do a simultaneous aspiration on the T24 at the same time as your T20. So, and then if you need to, you could pull both of the catheters back. One final thing I would add is looking at the truncus anterior. That could be sometimes a little bit challenging, and utilizing a double wire technique can be extremely helpful there. So basically what you leave up, typically for me, it's a 1 centimeter tip Amplatz wire. I have it sitting somewhere in the right pulmonary artery. And at that point in time, I pull the catheter back when it is sitting up there on the truncus anterior. Take a second catheter with a guide wire to select the TA. And then at that point only do I give up the buddy wire and then utilize a dilator to advance. You really don't have to get into it very far. Just get into kind of the origin a little bit past that and do an aspiration there as well. And that could be a very useful technique.
Okay. Zarina, any other techniques or advice you want to paint on?
Yeah, I think early on I used to be very sort of OCD about, the PA pressure pre and post. In my opinion, I think what I would love to see each case is a 50% drop in your PA systolic pressure, and I feel good about that. But it's not necessarily that you're going to get that every time, and I think that that's okay. If you see other clinical indicators that the patient is improved, their O2 sats, their oxygen levels have dramatically, how much they're requiring has come down, their heart rate's coming down, they feel just like their breathing is better. I think that these are all things that you should look at, not just the PA pressure as a sign of success. And then on the angiogram too, I used to get really frustrated in terms of just like how to get a good angiogram and I think it honestly comes down to a lot of how much sedation you give the patient, because obviously if you're trying to take an angiogram and the patient's moving, you're going to just get crap quality images. So I think making sure that you sort of coach the patient through that so that you get a nice angio at the end is a good idea. And even if you have small residual thrombus that's more distal, I used to kind of obsess over it, but if you have other clinical indicators that say that you've made a difference, I just usually leave that.
Okay, so that was actually my next question. So when do you call it good, like your endpoint? How much clot do you have to get out, and not how distal do you have to go, but Zarina, you kind of answered it with the clinical picture kind of dictates it. Ripal, do you have any other color commentary on endpoint?
Yeah, I mean, it's something that we always struggle with, when are we done? As I mentioned earlier, I'm really looking at three things. Again, the most important thing is the patient who's hemodynamically not doing well. If they get better, that to me is the most important thing. But a lot of these intermediate risk patients, maybe they'll be a little tachycardic, but otherwise they're normotensive, they're satting okay. So that you can't always utilize that as a clinical endpoint, but if you can use it, I think it's the most valuable thing. The other two things I'm looking for is obviously the angiographic appearance and a drop in the systolic pressures and the PA pressures, and it's something that we measure every single time. And it's something that, maybe in the future we could start looking at cardiac index, but it's a little bit harder to do kind of real time. But those are the three measures that we're looking at.